COPD, or chronic obstructive pulmonary disease, is a preventable, slow progressive respiratory disease. This respiratory disease, the incidence increases with age. COPD is not fully reversible, and somebody cannot be cured of COPD. However, our goal as nurses are to manage the symptoms and attempt to slow down the progression. COPD is due to a chronic inflammation that over time leads to a narrowing of the airways. And the airways that can be affected are the proximal and peripheral airways. So the proximal airways, these are the trachea and the bronchi. These things are greater than 2 millimeters in diameter. What happens in the proximal airways is there's changes in the goblet cells. And goblet cells are those mucus secreting cells. It's important, and these are normal. The body normally produces some mucus to help catch any foreign bacteria in the upper airway. However, with repeated inflammation with an individual with COPD, this leads to a hypersecretion of mucus of those goblet cells. The peripheral airways, these are the bronchioles, and the inflammation over time causes a thickening of the airways, which causes them to narrow, and it leads to scar tissue. A person with COPD also has alveolar wall destruction, and this leads to a decrease in that elastic recoil in the lung fields. They can also have pulmonary hypertension, and this is something we'll talk about a little bit later on. The two types of COPD that we're going to talk about, or the two subtypes of COPD that we're going to talk about, is chronic bronchitis and emphysema. An individual with chronic bronchitis, their proximal airways have been affected. The two hallmark signs that you'll see are excessive mucus and coughing. These individuals are also at a higher risk for developing upper respiratory tract infections, and this is due to that hypersecretion that occurs. All that extra secretions plugs the airway, which then reduces that ciliary function, which helps to normally keep bacteria out of the lungs. Somebody with emphysema, their peripheral airways are altered. They will have impaired oxygen and carbon dioxide exchange due to that alveoli destruction and overdistension. That overdistension is due to a decrease in elastic recoil, which leads to that increased dead lung space. And in that decreased lung space, or that dead lung space, there is no gas exchange which is occurring, which can lead to hypoxemia. Emphysema is much more progressive than chronic bronchitis. The single greatest environmental risk factor for COPD is that of smoking. This does not only include cigarette smoking, this also includes things like pipes, cigars, and other types of tobacco. Passive smoking or secondhand smoking can also increase one's risk of developing COPD. Smoking not only irritates the goblet cells, but also obstructs airflow, leading to a distension of the alveoli. Occupational hazards would include things such as dust and chemicals. When we look at clinical manifestations of chronic obstructive pulmonary disease, there are three kind of hallmark symptoms that we often see. This would include a chronic cough, sputum production, and dyspnea, all of which worsen over time. Other symptoms that the client may present with would be a low-grade temperature due to a possible infection. They may also complain of weight loss, and this would be due to the difficulty that they have with breathing while they're trying to eat. In the later stages of COPD, we will see things such as a barrel chest, clubbing of the fingers, The client may also use abdominal muscles to breathe. They may also have tachycardia as their body is trying to compensate with the low O2 sats. If you look over at the pictures on this slide, there is an example of a barrel chest. A barrel chest is due to air being trapped in that alveoli, leading to a chronic hyperinflation. Clubbing of the fingers is a sign of lung disease that is very oftentimes found in clients with chronic hypoxic conditions. When caring for a client with COPD, it is extremely important to do a full history and physical on the client. We would want to gather information related to their smoking history, their compliance with their medications, if they are O2 dependent at home, and if they have had any past hospitalizations for their COPD. We would want to ask some questions to find out if they are having a productive cough, and if so, what that sputum looks like. We would want to find out what makes their breathing better or worse. We would also want to ask questions to see how their breathing has been affecting their nutritional intake. We would want to do a complete respiratory assessment on them, not only listening to their lung sounds, but also looking at their breathing pattern and rate. Pulmonary function tests are used initially to confirm the diagnosis of COPD and then completed routinely to monitor the disease progression. Arterial blood gas measurements may also be obtained to assess baseline oxygenation and gas exchange. In a client who is experiencing an exacerbation of their COPD, we would expect to see an elevation in their CO2 levels on their ABGs. This would be from the carbon dioxide being retained. The picture on the right is an example of a chest X-ray. You can see there is a normal chest X-ray and then an example of a chest X-ray with somebody with emphysema, and we can see that over distension from that chronic inflammation within the lungs. When referring to medical management, bronchodilators are oftentimes used for symptom management in clients with COPD. Bronchodilators can either be short-acting or long-acting, and they can be used in the hospital setting, but oftentimes patients also have bronchodilators to manage their symptoms at home. Bronchodilators relieve bronchospasms by relaxing smooth muscle tone. They also help to improve alveolar ventilation by widening the airways and promoting lung emptying. During an exacerbation of COPD, corticosteroids are highly used as they help to decrease any inflammation in the lung field. Just like a bronchodilator, corticosteroids can be delivered through an inhaler or through a nebulizer. Corticosteroids may also be given intravenously or orally. Corticosteroids given intravenously or orally should be done for short-term use only, as long-term treatment can lead to things such as osteoporosis, muscle weakness, or a decrease in the body's ability to fight off infections. Depending on the client's needs, they may also be prescribed an antibiotic, a mucolytic agent, which would help to thin any mucus, or an antitussive agent, which would help to prevent or relieve any cough. A narcotic may also be prescribed if the client is complaining of a lot of discomfort, especially from that increase in frequency and that harsh cough they may be experiencing. They might have a lot of discomfort in their rib area. An anti-anxiety medication would help to reduce any panic and also help to relax the patient, leading to improved ventilation. Vaccines are also effective in that they prevent exacerbations by preventing any respiratory infections. A client with COPD is recommended to get both the pneumococcal and influenza vaccine. Depending on the client's situation, oxygen may also be needed. It is important to gather information to know if the client is O2 dependent at home. And as we know, it is very important to make sure that we do not over-oxygenate our COPD clients, as their drive to breathe is based on decreased O2 levels. Supplementing these clients with high O2 can actually lead to a retention of carbon dioxide. As the client's symptoms begin to improve, we want to encourage them to participate in their self-care activities to keep them at a baseline status from when they came into the hospital setting. We want to encourage them to rest when they need to avoid any fatigue or excessive dyspnea. We want to educate the client to space out their activities throughout the day. And it is also recommended that the client wait 1 hour after waking up to complete any self-care activities. Waiting an hour after rising allows for any bronchial secretions that may have collected in the lungs during the night to be expelled. As I mentioned earlier, weight loss is oftentimes a significant problem for a client with chronic obstructive pulmonary disease. We want to encourage the client to increase their calorie intake since they are using a lot of energy to breathe. We would also want to encourage the intake of fluids to help prevent any thick mucus buildup. We would educate the client to eat small, frequent meals to avoid them becoming dyspneic while eating. The nurse should educate the client about pursed lip breathing, as this type of breathing helps to slow expiration, prevent collapse of the small airways, and control both the rate and depth of their respirations. As far as activity tolerance, we want to encourage as much independence as we can with these clients. Graded exercises, especially that of walking, should be highly encouraged as they help to improve symptoms and exercise tolerance. Oftentimes, other disciplines such as a nutritionalist, an occupational or physical therapist may also be consulted on this client, as they provide great benefits to fully help the client manage their symptoms, especially when they move on to the home setting. As the nurse, we also want to talk to the client about things to avoid, such as high altitudes, as this can cause hypoxemia. We also would encourage them to avoid extreme cold temperatures, as this causes bronchospasms, and also to avoid extreme heat, as an increase in heat not only increases the body temperature, but also increases the O2 requirements. If the client is still an active smoker, we would want to talk to them about smoking cessation and offer them things such as a nicotine patch or gum. We are frequently monitoring these clients for signs and symptoms of an infection or a pneumothorax. There is a wide variety of pulmonary rehab programs that are available to clients with chronic obstructive pulmonary disease. This is done in an outpatient setting. Most pulmonary rehab programs are about 6 to 10 weeks in length, and the client on average goes about 2 to 3 times a week. As I mentioned, though, there is a wide variety of different types of pulmonary rehab programs. The goal of pulmonary rehab is to reduce or manage the client's symptoms, to help improve their quality of life, to increase both their physical and emotional strength by increasing their endurance. Not only does pulmonary rehab help to reduce hospitalization and improve exercise capacity, it has also been shown to help decrease depression and anxiety for clients with COPD. Pulmonary rehab services are multidisciplinary and include things such as smoking cessation, physical reconditioning, nutritional consulting, and psychological support. I already mentioned on the previous slide about things the nurse would want to educate the client on, things to avoid. As the nurse prior to discharge, we would also want to ensure that the client had a full understanding of any medications that they may be taking at home. If the client is being discharged home with an inhaler, we would want to educate the client to rinse their mouth after each usage. And we would also want to educate them not to overuse the inhaler, as this can cause heart dysrhythmias, or they may experience some palpitations or an increase in their heart rate. If they are prescribed an antibiotic, we want to ensure that they understand to take the full dose of the antibiotic. And if the client is prescribed a steroid at home, we want to educate them and ensure that they understand that they must taper off their steroids. Tapering off the steroids allows the adrenal glands enough time to resume that proper cortisol production. So oftentimes what would happen is the client may take 40 milligrams of the steroid for a couple days and then decrease to 30 milligrams for a couple days and then 20 milligrams for a couple days and slowly taper off their steroids. Oftentimes, individuals in the later stages of COPD also experience pulmonary hypertension, which can then lead to cor pulmonale. This is caused by long-term pressure in that pulmonary artery from pulmonary constriction. And what happens is this causes the right ventricle to become enlarged from the increased workload and not function as properly. Symptoms that we'll see would be things like edema in the feet, distended neck vein, ascites from that accumulation of fluid in the body. Sleep apnea or obstructive sleep apnea is characterized by recurrent episodes of upper airway obstruction and a reduction in ventilation, which causes an apnea while a client is sleeping. One of the biggest risk factors of sleep apnea is that of obesity. Clients with a larger neck circumference, while they're sleeping, their upper airway becomes compressed. The hallmark signs of sleep apnea can be classified under the 3 S's, which would include snoring, sleeplessness, and the significant other report of the sleep apnea events. Clients will have periods of 10 seconds or longer of apnea, which causes their blood oxygen levels to drop, which then causes the client to awake. Oftentimes during a history and physical of somebody with sleep apnea, they will complain of feeling very tired during the day due to the fact that they are waking up quite frequently during the night from their apneic events. A sleep study is performed to adequately diagnose somebody with sleep apnea. This test is an overnight study that is performed in a sleep center, which monitors the client while they sleep. If the sleep apnea is attributed to a client's weight, it is highly recommended that the client undergo a weight loss program. In severe cases where the client is experiencing hypoxemia or hypercapnia while they are sleeping, they may be prescribed a CPAP, which is used to help prevent airway collapse and improve ventilation while the client sleeps. If the client's sleep apnea is attributed to a structural issue, they may undergo surgical management. For example, if they have enlarged tonsils, they may have a tonsillectomy. They may also undergo surgical reconstruction or surgical management of the nasal or mandible area. Unfortunately, when we talk about lung cancer, this type of cancer develops very slowly, and oftentimes the client is asymptomatic until the disease has progressed into the later stages. The most frequent symptom of lung cancer is a cough, or if the client complains of a change in their chronic cough. Depending on the size and location of the tumor, the client may also complain of dyspnea and chest or shoulder discomfort, which would indicate that there is chest wall or pleural involvement of the tumor. After diagnosed, the client is oftentimes evaluated for any metastasis to any surrounding lymph nodes, bone, or brain. When being evaluated for lung cancer, the client would undergo a chest X-ray or CT scan. If needed, a needle biopsy would be completed to aspirate cells from the suspicious area that may have been picked up on the chest X-ray or CT scan. As I mentioned, the client would also undergo PET scans, abdominal scans to look for any involvement in the liver, a CT scan to look for metastasis to the brain. Medical management of a client with lung cancer takes into account not only the stage of the disease, but the patient's physical status. Surgical resection is the preferred method when treating clients with lung cancer when they have a localized tumor and no evidence of metastasis, and if the client is physically capable of undergoing the surgical procedure. Radiation may be used to help reduce the size of the tumor and also help to relieve any pressure that the tumor may be having on vital structures. Chemotherapy may be used to alter the tumor growth patterns and to treat any surrounding metastasis. Every client situation is individualized, but the client may have a surgical intervention along with radiation and chemotherapy. Depending on the client's physical status and emotional status, they may be ineligible for any surgical intervention or may also not be a candidate for chemo and radiation. This is where we would want to include palliative care to help manage the client's symptoms. Palliative care is used to help plan for a comfortable and dignified end-of-life care for both the client and their family. As the nurse, we want to focus a lot of our attention on helping to decrease any dyspnea by educating our clients on proper breathing exercises to help promote lung expansion. Unfortunately, these clients oftentimes complain of fatigue due to the constant pain and discomfort, hypoxemia, their poor nutritional intake, and they oftentimes suffer from sleep disturbances. We want to provide emotional support to both the client and their family and provide them information regarding possible treatment options when they are making any informed decisions. We also want to discuss with the client their end-of-life wishes as far as their care. Occupational lung disease, you may also hear referred to as work-related lung disease, occurs when there are changes within the lungs after the inhalation of any occupational hazards, such as mineral dust, toxic fumes, and metal dust. The lining of the lungs becomes very stiff, and there's a buildup of scar tissue, results in somewhat of a pulmonary fibrosis. Unfortunately, occupational lung disease is not treatable. However, it is very preventable. So there's a lot of education that comes into preventing such occupational lung diseases. When completing a health history, it's important to know that the agent that the client was exposed to and the length of time that they were exposed to it. In the early stages of occupational lung disease, the patient is usually very asymptomatic. It's usually very advanced once discovered. Signs and symptoms of the lung injury may not show for 10 to 30 years after exposure. We also want to know if the client has a history of smoking, as this increases the risk of the agent. Your Brenner book does a nice job of reviewing all the most common types. So I would definitely take a look at the different signs and symptoms and be able to compare the difference between some of these common occupational lung diseases that we'll see.